So thank you. I'm very mindful that I stand between you and morning tea, so I'll make this brief. And I guess to counter John's comment about noradrenaline, we're pretty pragmatic intensive care specialists, and if a colleague believes that noradrenaline by peripheral line is appropriate for a short time, we would accept that patient very gladly. And ICU registrars under my watch don't take 8 hours, that's for sure. So I'm going to give you a brief, history through where we've evolved intensive care services network and what is now Intensive Care New South Wales. The title, What's in a Name, will become sort of, you'll get a better understanding why we've chosen that title. So I guess to put it into a bit of context, I'm one of the clinical advisors or medical advisors at ECI for the Intensive Care Services Network, and I support Sean Kelly's role as the medical lead. So to give you a little bit of background, back in about 2000 there was a review, and born out of that review was ICMU. Okay, so it started out at Nepean Hospital in this little office, and role was really to look at providing some expert advice about intensive care services across the state, and really we sort of novel at the time to bring a group together as a conduit between what was then the department and now sort of the equivalent ministry and clinicians to actually sort of work out how we were going to best be a conduit between the two groups. Priorities then were sort of formulated. A lot of it was around sort of service provision, quality, and how we would actually ensure the minimal clinical variance. So then post-Garling report, as you know, the ACI is formed, and then we became under the banner of sort of ICMU, and there was sort of this in its infancy, ICMU as a brand had become really well established. In fact, we had ICU Connect, and ICMU was a really sort of Googled and hit, where we had international people, nurses and clinicians on the sort of chat line, and we evolved to become the Intensive Care Services Network and ICMU under the banner of ACI. So it was all this sort of language, and even we got confused about what we should be called. So then we became Intensive Care New South Wales. So the old kid in the block has now grown up, and what we then became was moved from, it was earlier this year, we had a vote about it. It was sort of a room like this of intensive care specialists and clinicians, and we all sort of argue about what we should be called. Should we be called an institute? What were we? So just to make it sort of simple to, put into context and bring everything together about our roles were, we decided to call Intensive Care New South Wales, and so that was launched. Within the Intensive Care New South Wales, we have working parties or working groups. So performance, you can see there, rural CNC, ERIC, best practice, and nurse leaders. These working parties form to then sort of work towards a vision. And I guess our vision is really that the people of New South Wales should have timely access, as you can see, to quality intensive care close to where they live. This is a recognition that across New South Wales, ICU's become a valued resource within the hospital. Okay, we need to be able to promote sort of, which was what we're all doing, quality care, but what we see time and time again is that there are holes in the system and cracks in the system that intensive care as a craft group was plugging in a lot of places. And we then formulate our strategic sort of priorities, and you can sort of see it's all pretty standard. You can pluck this out from most sort of agencies, where what we really want to do is have a whole just to give clarity around what we were doing and what our role and our purpose were. And there you have sort of the team. We've now got so Kelly Cridland is our program manager, and we now have a research officer as well. So I think we are trying to mirror the ECI from the point of view of developing a research strategy within the intensive care services, and Intensive Care New South Wales, and also to try and build capacity in the future and leadership in the ability to have trainees come with us. So, talk through about what's in a name, okay, the evolution of intensive care, ICMU and so forth, Intensive Care New South Wales. The next component of what's in a name is really about the concept of HDU. ICU versus high dependency versus closed observation unit versus COB, okay? And as we went and spoke to clinicians, we realised that there wasn't a commonality about this language. What was an HDU or an expectation of an HDU in one hospital wasn't quite what it was somewhere else. Okay, so there's all this language, nurses and patient flow and managers spoke about HDU, and we then have sort of an ICU, there's under an ICU specialist and so forth. Okay, ICUs of yesterday, hospitals of yesterday, the ICU bed or bed stock was 3 to 5%. We suspect that with complexity of patients, I think that my bias is that there is an element of skill, the lack of skills from junior doctors as well, and registrars moving through because of the nature of their training, that the ICU requirement in the future is going to be of the order of maybe 20 or 30%. So born out of that are these sort of mega units. How are we going to rationalise that? Does that make sense from a sort of a government and, you know, because it's a high cost sort of environment? How are we going to plan? What is the optimal bed number? Okay, I don't think 30% is the right number. It's going to be somewhere less than that. But how do we create an environment that's safe for our patients? And there's now an expectation of care that we need to be able to provide a certain level. It's not quite ICU. Is ICU just about the tubes and the lines? No, there are some complex patients who don't fit nicely into a box, and where should they go? Overall, if you look at ICU mortality, and we can see that we're getting better. So it's not about the fancy drugs and the machines and all these strategies within the intensive care that's making a difference in sepsis. It's actually about the quality of the care, and there's something that we're doing, it is making a difference over the years. Despite that though, we can see that there's variance. Okay, there's definitely clinical variance across the state, and born out of the recognition of that variance and the discussion about what is ICU, what is HDU, and how we're going to define that, came the intensive care services model. This was a sort of one of our first sort of bodies of work, and it is now the major that takes up the major block of time for all the clinicians who work in Intensive Care New South Wales. So the service model is really a framework to allow some consistency in regards to the language, and the key to it is to be able to support smaller intensive cares and smaller hospitals to be able to have a structure in place that allows them to look after and care for the patients at the appropriate time, at the appropriate place. Not necessarily meaning they should all be shipped out, okay, or transferred, because that has an impact on retrieval services, on hospitals themselves, on the staff, and let alone the patients and their families. So it's the recommended standards as a framework, as a document that allows hospitals to go, okay, well, in order to be a level 4 intensive care, this is what you need. There's recommended standards. It's born out of the concept of an integrated intensive care service across an LHD. So an LHD may have one level 6, and they may be networked with a level 4, for instance, okay, within the one network. Or you might have a level 6 in the metro, and you're networked with a level 4 in a different LHD. We tried to move away from the concept of closed and open, okay, because it has sort of negative connotations. You know, it's more about a collaborative model. It's a discussion that, yes, we do need some sort of medical leadership within the unit, but it's working with the clinicians who the patients might be admitted under. The concept around 24/7 access to critical care advice. This has always been a challenge for the smaller units. Where did they get that advice from? Often, at times, it is the ED specialist or the ED staff at 3 o'clock in the morning. How to create a system that allows better defined lines of communication to support the smaller hospitals. We want them to be able to have some standardised practices and processes, and ultimately it's about that patient at the centre of all this to see whether, if it's feasible and safe, can we provide the care for this patient closest to home. So an EOI was established and 19 sites were in scope. And you can see from how, I guess, give you an understanding of how extensive this project has become, is that in phase 1 there are 9 ICUs, and some of you in the room may actually be from these hospitals. So 9 ICUs in phase 1 and 5 ICUs in phase 2. So we're at the tail end of phase 1 at the moment, and underpinning this project is the support from the ECI, the implementation team, the intensive care New South Wales staff, but underpinning all this is about the responsibility and, I guess, what the LHD can provide and ensure, which is sort of the executive sponsors. So very much the approach is, we're not going to go in there and give them solutions, because we know that what we want is sustainability. The process is in order to allow them to help work out what local solution might work for them in their circumstances. Sorry, I've been moving it here and haven't been moving it there. So it's a pretty comprehensive sort of implementation strategy, and it is outlined by these sort of 9 recommended standards. So if you think about leadership and governance, care planning, we'll go through each of those and how we might tailor it to a local hospital. Okay, so the leadership and governance concept is, there should be an intensive care. If you choose to be a level 4 ICU, there needs to be an intensive care specialist who's the director. This creates the potential problems that you might sort of say, we can't. The ability, intensive care now training is geared towards a single specialty. Okay, you don't have dual trainees as much as you, and into the future you won't. So there's a recognition that there will be centres that there may be one intensive care specialist as the director, but they will be supported by clinicians with the same skill set or similar skill set to fill the rest of the roster in a way. Okay, it requires sort of having a NUM, and these structures, it all sort of sounds really simple, but as we went through, we realised how there were so many places that actually needed some help just formulating that. Make sure they have standard protocols, have M&Ms, have quality assurance. Make sure that when a new medical staff member arrives, there's adequate orientation. We were hearing anecdotes of a locum doctor, for instance, coming in and there is no form of orientation. It's really, this is it. You're looking after this unit, and no other forms of orientation, the orientation package. And we're trying to sort of help units put processes in place that allows this in order to sustain staffing models in the peripheral hospitals. We have overlaying The implementation process is some tools, which is a combination of online as self-assessments with capability training, so remote support, so via email, via teleconference, by Basecamp. The local sites can email centrally and ask questions and keep in touch with Intensive Care New South Wales. There are site visits. The site visits are 2 to 4 weekly, so our staff are constantly flying out to all the sites in order to have face-to-face meetings by teleconference, whatever we can in order to support them. All the sites that started in the phase 1 did a self-assessment, and they're not identified there, but you sort of see sort of hospitals A through to N, and using the tools with those standard questions: do you have a medical leader? Do you have daily ward rounds? Who looks after your pathology? Do you have equipment, M&Ms? Those sort of all those self-assessment tools. You can see that the state average was about 50% compliance. Although there were some hospitals that were at baseline were doing really well, had a lot of already established practices. There were those that clearly needed to, I think the advantage of this particular tool was mainly around them being able to identify what the deficits were. Really sort of put it down on paper rather than suspecting what it is. So the implementation team, as I said, they did the self-assessment first, and it's the implementation over the period was phased in, and then they would reassess. You can see from the timelines of the phase 1 sites, it was quite an extensive timeline. We believe that the ECI component of the implementation is probably about 18 months, although there are some sites that are still at the tail end of that. But in order to establish this as a sustainable project or a sustainable initiative, we believe it's a transition of probably 2 to 3 years. There are some lessons learnt in phase 1. So when we've taken on the extra 5 sites, phase 2, the timelines have been a little bit faster. When sites have done a repeat assessment at the 12-month mark, you can see that at a state level there's been an increase overall in regards to compliance to the recommended standards. It's notable, though, that there are a few sites that still remain at below state average. Okay. What that has led to is some units, although initially putting their hand up and saying, look, we want to become a level 4 intensive care, they've decided that actually it's more appropriate for them to be a closed observation unit. So the closed observation unit has got similarly the draft document. So the document is still in draft, but again, what we're trying to do is standardise what a closed observation unit means, how that's different to a level 4 ICU and how that might be different to a level 5 or level 6 ICU. What we think the key achievements have been is that there's certainly improvement in medical leadership. That is not without its challenges. So I was certainly talking to an area administrator yesterday who said that his current ICU or his brand new ICU recruit as part of this strategy is under attack. Because they've been very well, systems have worked very well for a long time. And how the local health district manoeuvres through some of those politics as well has been challenging at some places. We have seen an improvement in governance, quality and safety monitoring. They now have networked M&Ms, for instance, which they hadn't had an opportunity to do in the past. Education training and simulation, which is streamed across hospitals which are linked as level 4, that's linked to a level 6, and the formation of formal networks and memorandums of understanding and service level agreements that talk to how the relationship is beyond the personalities of one director and another director over the years. Even within central Sydney, rather than thinking through, out further west, or there's been an initiative to rotate nursing staff. And again, underpinning all this is being able to empower the smaller hospital to keep patients for as long as they believe it's appropriate for them. The projected outcomes, we believe, is that might be there's between a 10 and 15% reduction in transfers, and you can sort of see there in regards to patient experience and so forth. What we've really discovered in looking all this is when we've moved, we've gone to these hospitals to talk about the level 4 rollout. There are lots of implications beyond the intensive care. It's how the surgeons may have interacted with the intensive care unit. It's how the physicians might have in the past, when what was, and what, in the old terms is open ICU, no gatekeeper, and with no rules about who should go into that unit, who should, what are the appropriate admission criteria and so forth. There have been many times where we've gone in to try and help manoeuvre through some of that for the local staff. We think there are lots of benefits to people at least just being able to talk to each other, and not in sort of the ad hoc way that has occurred in the past, dependent on personalities. We want to be able to encourage people to know that Dr. X who've called, they've met them at some stage, or they know of them, and there is a natural relationship between two hospitals. And as I said, at the moment, there's still hospitals trying to manoeuvre through who they'd like to network with, but in this process, that gets formalised. So the phase 1 sites, considered a 24-month self-assessment, will be in February 2018, and phase 2 sites at the moment, they're still having monthly support, and they'll redo their assessments. The projects, I guess, coming out of, last 2 slides. The project that's coming out of the intensive care services model is evaluating the model implementation itself. How well that's worked with the support. So from an ACI executive level, there's discussion about could this implementation program apply to other projects that may be rolled out in ACI. Exit block is another project that we're looking at, and I think the final thing that is relevant to the level 4 rollout is the concept of when we've had a look at the database of ICU to ICU transfers. So this is a hospital that is categorised as an ICU, whether it's rural, whether it's metro, whether it's tertiary, and they have sent a patient to another ICU. There is a spectrum of severity of illness in that group and mortality, meaning that there are some patients who are transferred appropriately because they're really sick and they need ECMO. All right. On the other hand, on the other scale, there are some patients who are being transferred because of lack of systems in place that, and in fact, within 24 hours of being admitted to a tertiary ICU, they have end-of-life care initiated. So the postulation is that maybe in these patients, end-of-life care could have very well occurred at where they've lived. And then there's this group all the way in between who may have only needed 24 hours of ICU in a tertiary, and they've been moved to a tertiary centre, and with the appropriate support, that 24 hours could have occurred at the rural centre or at the level 4. So the future is trying to better understand these transfers. That project is about ICU to ICU, there are a whole lot of implications into those that gets transferred from ED directly to a tertiary ICU. And I guess be on the lookout for, if you're at a hospital where this project is being rolled out, to have that conversation, to be aware, okay, well, now we've got these services, have some trust that there's enough support and the structure to allow you to have some confidence to refer the patient to your local level 4 ICU, rather than transferring them as that sort of gut feel that, no, I'm going to just send them out, because the implications of the transfer back and all those sort of things we haven't measured well. So I'm happy to take questions with a minute to go. But again, this is sort of on behalf of the intensive care team. Thank you. Any questions?
Any questions? We've got a half hour for the morning tea, so we can stretch if we need to. Maybe I'll head off. I work in a big place in the city now, so not quite so much exposed to it, but I got a sense that it was the retrieval doctors that were working at keeping that patient there, and I know a lot of retrieval doctors and work briefly in the area, and they were in that sort of space of saying, well, maybe we could stay there, or even getting out there and leaving somebody there, particularly this approaching end of life care and saving that, and it's great to hear that the networks are now probably much more established in terms of that decision, so that the decision comes from ICU here or whoever's surrogating for that, talking to the ICU where they might be going. Yeah. Is that something that you've found has changed a lot in the last 5 or 10 years, or is this still something that you're aiming for?
I think it's something we're still working towards. I think that there is still anecdotally lots of pockets, lots of examples where there have been concerns because they're not sure who the next locum is, who's working. They're uncertain about whether there's a nursing skill mix and so forth. And those sort of influences of decisions that are poorly defined. Okay, so when a retrieval team says, no, I think you should keep the patient here, and they're going, no, we can't, and you're trying to understand why that is. So I think that the process of this sort of, particularly the networked sort of setup, is that the rural centre gets to have a conversation. The guideline is for them to have a conversation with a level 6 every day. So a touch base to say, I've got this patient in my unit, these are the things we've done, what do you think? And it's being able to bounce ideas off so that they have some sort of support, or there's the phone call that says, actually, I need to bail. I need to bail, we've struggled for these reasons, and can you please take? So we saw that happening in the past because of personal relationships, where a colleague will call because they know their friend's on, but it's trying to establish it within the system so it's not so dependent on individuals. Matthew?
Will we be in a situation whereby the level 4s will have a system whereby you've got video linking of that particular bed, just as it happens in some of the hospitals in New South Wales and certainly some of the hospitals in Queensland, so the intensivists at the level 6 will see, okay, for my own eyes, this is what's happening.
So, Matthew, in fact, there is a vendor, namely Philips, and that should probably be shared only in this room, who have been campaigning really hard for a system whereby that occurs. We think that, so we canvassed a forum of specialists and clinicians, so the ICU, both nursing and medical and allied health, in a forum such as this, to say, is there an appetite for it? And there certainly is. The elephant in the room is really about the human sort of, the human factor component of, I can't quite feel and see that patient, and let's just send them. So we're trying to overcome that, but certainly sort of video linking and who's ultimately responsible for that patient. So America, well-established system where they have, in fact, a room of 8 nurses and doctors who oversee 700 beds, for instance, across the country, remotely. So there was actually a virtual an ICU like that set up at Macquarie Hospital, which is currently being moved over to Western Australia, and it oversees 600 beds in the States. Okay, and it's a monitoring system where literally there's video screens and they sit there and they scout and they see a patient whose alarm's gone off and there happens to not be a nurse there, and they dial in and they say, hang on, the alarm's just gone off on that patient in that bed, can you go and check? And that system can't translate, that naturally doesn't seem to translate well directly to the Australian environment, but the signal is that there may be some sort of role for it, certainly in smaller centres that have trouble with providing 24-hour care.
This is talking about the rural areas, but in our system, in our tertiary hospitals also, there are situations where you have, like I work in emergency department, all of us do, you have patients who are nearing NFR, but the doctors are not keen to talk to the relatives about the end-of-life care, and hence they get shipped out to ICU. Obviously, if it happens in the middle of the night, the consultants do not come in and see the patient, and they find it very easier to say, okay, overnight, bring it into ICU. However, ICU beds are pretty limited,
Yep.
and this occupies the beds, so the next person who's supposed to go to ICU, say a 50-year-old as opposed to the 90-year-old who's occupying the bed there.
Yeah.
Have you guys come across these situations? Like, there's lots of over 85s sitting in ICU who don't need to be there, but the consultants are keeping it there.
Yeah.
Certain times it's because of money, and certain times it's because of the they don't want to get the conversation started about end-of-life care.
Okay.
I'm coming across a lot of this in our hospital. I don't know if you guys are also or not.
Yeah. So I think that the reason why the ICU bed stock probably needs to be more than 5% is this culture creep of whose job is it to do it. Okay. And absolutely, I think that we can be practical about it and saying, well, who actually has the skill mix, who can do it. Often it's like in crisis. There are initiatives of end of life starting from the GPs and primary health all the way through. There are challenges to it though, in that if patients are asked at the wrong time or families are asked at the wrong time, then that's not appropriate either. So we've got patients are saying they're sort of gasping for air, and they're on 100% oxygen, and they're saturating 85%, and someone says to them, do you want to be intubated? That's sort of not unless that it was discussed a long time previously. So I think there is a balance. I think most of us feel if you get a room full of intensivists, those who've worked for a long time and those who are sort of more junior or younger, there's a sort of range of those who says, well, it's our job, and those who say, well, no, it's someone else's job. And I think that in the end, it's really about the patient. And I think we do make pragmatic decisions, and we hope, and even in intensive care, intensive care, we get it wrong sometimes. It takes us, and we look at it at M&Ms all the time. In retrospect, we knew this 3 weeks ago. Why, 3 weeks before they died, why have we carried on? And it's just the pragmatic, a balance of expectations of the community, expectations of our own colleagues, and trying to balance all that. Sorry.
I can talk loudly.
Yeah.
More actually a comment. I actually work in one of the hospitals that's on that list there. We're just moving towards this closed or collaborative ICU model. One thing from ED, though, that is difficult, and as you've just alluded to, is community expectation. Yep. And when you work in a regional centre, tertiary hospitals in Sydney are seen as the God saviour for everything. And if you are not transferring their relative to Sydney, then you're not treating them to the best that they could be treated, and that is a real pressure on the hospital and then on retrieval services and on the big, obviously the tertiary centres, that people expect that if they need ICU, they should be in a tertiary centre.
So I guess we hope then the language is actually we have daily contact with our colleagues in a tertiary centre, and even if developing that sort of relationship. So actually we have daily contact and assure the family. I said it's not going to be easy. There's a whole lot of family expectations and community expectations. It's certainly retrieval, hospital beds, everything is not an endless resource, as you know. So I think we try to get them to frame around, yes, you're going to move all this way, that we're not going to provide anything differently to what is being provided, on the basis that we're providing the appropriate support that allows the right skill mix to be sustained in that intensive care at the small centre.